chronic left ankle aching pain, which has a gradual onset over the past 6 months and a progressive course. Increases with prolonged walking or standing. I tried some patient had injection of plasma and 5 months ago. There was some mobilization in a knee cast. I tried for 1.5 months. I tried a physical therapy program, but there was no improvement. The examination was weak. There's no deformity, no tenderness or instability.
Okay. So I'm not going to have a patient walk because of that. The guys did a phenomenal job really getting this video rectified. Seems like there's an intro line. Right. Well, okay, let's stop here. باشمهندس سامي. ممكن تقول لنا رجلك الشمال بتوجعك فين؟ لو هتشاور بصباعك واحد على الارض حته بتوجعك. طيب والوجع ده رجلك بتسيب او بتكتب منك no giving way, no instability. He localizes his pain to the anterior corner of هنا. This is actually anteromedial. So he's localizing the pain anteromedially and his lesion. What's his lesion here? This medium? Okay, so that's good. So I like that. That falls in the of what we were talking about. So أحرك فوق وتحت. So I'm feeling for preparation, just to listen to the press of that. We'll go over. Okay, and then just for the sake of time, he seems like a sensitive guy. Neurovascular intact, his lower test is okay. His varus test is okay. These you want to do a valgus stress, so I'm actually going to. There might be something deltoid or valgus instability. So I'm actually stressing him right now. Back. It's pretty stable. So no instability. Everything looks nice. So this is a case which adds up. He's pointing with the finger anteromedially. The upper hip of the back. Look at this. He is a very, this is a patient I like. He's an intellectual guy. He's an engineer. He says, with walking, I have mechanical symptoms, severe pain in my anteromedial end. This adds up. This is the scenario I want to hear. Okay, let's go for his image. So you saw the difference between both scenarios. So here's a medial osteochondral lesion. Again, this is mostly, it is superficial, it's not deep. I don't know why you like to go to the T1s, which is fine. Always go T1s and T2s, but when I assess these, I want to look at the T2s. So do you have T2s? No. Okay, so just for teaching sake, or protein density or fat sat, okay, let's go back again. Yeah, so this is the lesion. Okay, that's okay. Let's go to the axial. So again, remember the Laken out of Thomas Jefferson, zone 1, 2, 3, 4, 5, 6, 7, 8, 9. So this is a predominantly zone 4. And I published the validation, by the way, with the orthopedists who published the validation of the readings of the Laken zones. So this is roughly 10 millimeters, I would say, by what, 5 millimeters wide. What did the measure be? 10 by 5 and maybe 3 or 4 millimeters deep. Let's go to the. So yes, I think this is the person that to benefit from an ankle scope. What procedure are we going to do? Can we go to the coronas and the sagittus, please? Okay. Show me the protocol. You have the other ones. What's the first one? Yeah, okay. So here it is. So I think this is where the negate becomes. John was mentioning an intact cartilaginous cap versus a dilated cartilaginous cap. You might argue that this cartilage cap is intact. I personally, after doing 3 years of a PhD and spending time in the lab, believe that this palpable cartilage doesn't go in. Again, for the sake of time, I go in and I scope this, and I palpate the cartilage with the probe. If it is soft and palatable and I can easily go into it and scoop it out, that's that cartilage. Then I go in, take the cartilage out, clean the traitor, do micropressure, and get out. This is superficial lesion. John's argument that this cartilage is not palatable, which I agree, it is not palatable, it's like an eggshell. It's like an eggshell. You put the probe there, and then those toothpaste additives. You probe the eggshell and it's hard, then you can go from the bottom, aim it, and decompress it, and that's it. Making sure that you don't violate the cartilage gap. I'll leave it open up to the panel. If you have any other comments, please do. Yeah, so some people use the C guide, which I think the ACL guide is, we used to use the ACL guide in the old days. Now there's still a targeting device for, I don't know, do you have a targeting device for ACLs? So you can use an ACL guide and adjust it at the angle, because you want to come in, show me the coronal space. You want to come in from the lateral side, from the theta, so you want to come from here. So I put it there, I put the ACL guide into the joint, from the lateral cruciate, and I go over the top, and I aim my device there and shoot to it. If you don't have the ACL guide, you can do it freehand, it becomes tricky. Do it freehand. John, do you have any tips to do a lot of these? What do you use for aim? If you don't have that tailor specific guide.
Well, unfortunately, in Texas, we did reckon, as we say,
Yeah.
that basically taking a small K wire out there and having a C on to go back and forth to get where you want to be. I mean, if it's truly stable up there, yeah, you've got to be very careful and use that and drill from there to go with curettes at the final stage to get that up. The nice thing is here, there's not a strive rim. It's not something that you have to really break through here. And I think this is something you're going to find very loose by looking at it. This is relatively straightforward for you, reading it and making a decision if you're going to cover it or just be part of it.
Perfect. So yeah, so I think we're going to our way. We're going to go with aim for it. The question here is, are you going to, let's from the panel, let's say are you going to augment it with anything? Microfracture, augmented bone marrow stimulation. They're going to augment with a combo matrix, bone marrow aspirin concentrate.
I'm not a big fan of the bone marrow aspirin, things like that, but I have gone from doing just a microfracture to doing some of the cartilage recovery in there.
Which study is it? You don't have to name names. Is it micronized cartilage or is it juvenile cartilage?
Oh, it's micronized.
Micronized. So micronized is collagen type 2, which we don't have here.
Yeah, I do the same because it's available now.
Yeah.
Just the advance of that.
Mm-hmm.
Small lesion. Yeah, and active as well.
How about your blitz? What do you do? Do you augment microfracture?
Microfracture.
Just microfracture.
Good old microfracture.
Good old microfracture. I agree.
We're not adventures there.
Yeah, you should know that the literature says there is no superiority of using any augmentation in lesions less than 10 millimeters squared, which I believe this was like. So if it's less than 10 millimeters squared, confined microfracture alone is okay. I know of only one study out of HSS, out of my mentors, and I'm going to say it with bias, where they injected bone marrow aspirin concentrate. So they did not inject the VMAC into the joint. After you do the microfracture, you suck all the water out, you do a dry arthroscopy, and then you inject your syringe, your VMAC syringe, and drop by drop into the defect and let it sit with the clot. And that's sometimes when they do it's called augmented microfracture with VMAC. And then on a series of 25 patients, they found it. So it doesn't cost a lot of money to take an aspirin and spin it down here in Egypt. Because this guy already had PRP and he paid for it. So he can pay for a VMAC injection as well. It's not an injection into the joint, it's dropping it drop by drop. So that's something just we can try and see how it goes.
Decision for this patient to be?
An angle arthroscopy, probing the defect, either retrograde bearing and the cartilage cap is defect or not allowable. If it's allowable, then scraping is microfracture, and that's it. Thank you. This is what the literature shows. The literature shows that lateral OCDs are mainly traumatic instability. They're shallower, they have better prognosis. Medial osteochondrial defects are found to be mostly idiopathic, deeper, worse prognosis. This is what the literature shows. Any other questions? Let's move on. I think we're good for the job. Thank you.
Now we'll go on with the complex food sessions by Dr. Mohammed Goda and Professor Wahid.